So let's go ahead and get started and first talk about the difference in the anatomy between the male and female breast. As you can see from the images on the left, that overall in the female breast, there is stimulation of the ducts and progesterone in particular stimulates the development of terminal ductal lobular units, whereas in the male breast there's androgen suppression, so you don't have development of ducts, lobular units, and stroma. And if we go on and look at the images of the breast, you'll see this picture of the male breast here. It's composed mainly of fat, ductal tissue, and skin. And of note, it does not contain Cooper's ligaments and lobules. So when I look at the male breast, it always has a triad of findings where you have prominent pectoralis muscle, small nipples, and as well as a small nipple areolar complex. And that's in contrast to the female breast, where you will see Cooper's ligaments and lobules. And of note, because there are no lobules in male breasts, lobular processes such as cyst, fibrinomas phalloides, and invasive lobular carcinoma are extremely rare. A rule of thumb, though, is to diagnose common conditions such as gynecomastia and the rare instances of male breast cancer, you need to evaluate the male breast tissue as you would the female. So what I'm doing this talk is to go through how we evaluate the symptomatic male breast. And specifically, I'm going to be referencing the ACR Prognosis criteria for evaluating the symptomatic male breast. I am the current chair of this committee, and we went through the variants, 5 of them, where we talk about what type of imaging exams are appropriate given a particular scenario and given the level of suspicion. So I'm going to go through all 5 of these variants and illustrate it with cases. So in the male breast, the most common symptom is going to be a palpable lump. And really, there are 2 differential. Is it going to be gynecomastia or breast cancer? So let's look at this question. This is a 45-year-old male with palpable left breast mass and physical exam consistent with gynecomastia. So what is the most appropriate initial imaging test for this patient? Is it none, mammography, ultrasound, or choice D, MR? The correct answer is none. And here, what I've done is I've copied this variant 1 from the ACR Prognosis criteria. And we state here that any male patient, regardless of the age, if they have symptoms that are relatively benign and your referring physician thinks it's gynecomastia or pseudogynecomastia, in terms of initial imaging, none of these are appropriate. In other words, this is a diagnosis that should be made with confidence based upon the clinical breast exam. And here is an example. This is a 39-year-old male with a palpable lump in the left breast. You see we've placed an arrow here pointing to this is a small area which looks some normal breast tissue. On sonography, this is where the nipple is, and you'll see some non-specific hypoechoic tissue in this region, and this is consistent with what we call a left dendritic gynecomastia. I have a companion case to show you the different types of gynecomastia. Here you can see that in this gentleman, 75-year-old palpable lump, he has the same kind of pattern of this normal breast tissue, the bilateral gynecomastia. It is more prominent on the left side than the right, and this is what we're going to say. The right side has that dendritic gynecomastia, whereas on the left side has this diffuse, it's kind of flame-shaped gynecomastia pattern. And this diffuse gynecomastia pattern has the appearance that's similar to an area of heterogeneously dense breast tissue in the female breast. Another case for a companion, you can see here that this patient, here's a nipple. We placed a B marker for palpable lump. You can see a little bit of that flame-shaped appearance, but you'll see that this flame-shaped glandular tissue also blends in with the adjacent fat. On ultrasound, again, that hypoechoic area, here's a nipple. And this is really the very common pattern of what gynecomastia looks like on ultrasound. And in general, gynecomastia is extremely common. We see it in up to 57% of men over the age of 44. Usually, it's a bilateral pattern. In fact, patients may only be symptomatic on one side. And overall, in the literature, the nodular pattern is more common than a dendritic than the diffuse pattern. Just want to spend a few minutes talking about the etiology for gynecomastia. I like to break it down into 5 different etiologies. Can be physiologic, hormonal, systemic disease, drug use is very common, a long list, and as well as idiopathic. So physiologic quite often is along the 3 different age groups, and we see it most often in young men undergoing puberty or in the elderly male population. Hormonal setting of hypogonadism, sometimes patients undergoing treatment for prostate cancer as well, and also in Klinefelter syndrome. Systemic disease, usually in setting of gentlemen that have chronic immunoinsufficiency or cirrhosis. You can see here a very long list that's not complete, but these are the most common drugs associated with gynecomastia, and so sometimes it's idiopathic. But if the breast has those imaging patterns I showed you, this is going to be assessed final BI-RADS assessment 2, benign finding, for which treatment is just reassurance. We do not recommend follow-up imaging based upon those features. So, as I told you, here are the 3 different types of gynecomastia. Nodule is subareolar nodule. Usually sees in patients that have been symptomatic for less than 1 year. And the idea is after a year, there is a fibrosis that sets in, becomes this flame-shaped pattern. And usually, the gynecomastia at this point is not reversible. And finally, the diffuse glandular pattern, as I mentioned earlier, it mimics heterogeneously dense female breasts, and is usually associated with a higher level of estrogen circulating within the body. So I want to spend just a minute talking about pseudogynecomastia. This is where on clinical breast exam there is enlargement, but in fact we don't see evidence of this patchy fibroglandular breast tissue. In fact, the breast tissue we see is all entirely fatty, and that's because there's excess fatty deposition in the breast. And often we see these in patients who are obese or have an elevated BMI. And this is really important to diagnose because if the patient is already on medication, sometimes the doctors will assume that that's what it's related to, and therefore you can avoid changing medication if you in fact alert the physician that the diagnosis is in fact pseudogynecomastia and not gynecomastia. So here's another example of the pseudogynecomastia. You can see here there is that triad, the large pectoral cells, small nipple areolar complex, and here what you're seeing is just the fatty tissue itself without any evidence of gynecomastia. Now let's go on to the second question. Here, how do we manage men who present 25 years old or less with an indeterminate palpable mass? So here you can see now the clinical suspicion is indeterminate. It wasn't benign, think it was gynecomastia. So in this setting, what is the most appropriate initial imaging for this patient? Is it none, mammogram, ultrasound, or choice D, MR? And the correct answer is choice C, ultrasound. Again, I'm going to show you the second variant in the appropriateness criteria for the management of symptomatic males. And here, we focus specifically for male younger than 25 years of age who present with this indeterminate palpable breast mass. You can see that usually we will divide all the imaging exams into 3 different criteria. Usually appropriate, maybe appropriate, or usually not appropriate. So here you can see right away, MRI is not appropriate. Imaging with either mammography or tomosynthesis may be appropriate, but ultrasound should be the initial test to diagnose and further work up this indeterminate palpable breast mass in a male who's younger than 25. So this is what we know from the literature. that ultrasound is first-line imaging, and the usual workup is if suspicious findings are seen, then mammography should be performed, especially if we're going to be recommending a biopsy. And the reason behind doing mammography, you want to compare to the contralateral side, although synchronous bilateral breast cancer is exceedingly rare. So, gynecomastia, just to kind of show you, tends to have hypoechoic tissue, retrolar breast that may or may not have vascularity. And sometimes it can be this indeterminate. This doesn't look as classic like the other cases I showed you here. You can see it's a little bit more broad. The border is a little bit more indistinct. So this is something that we would probably want to follow, make sure that it's going to be benign. So now, how about this case? 30-year-old male with indeterminate palpable mass. What is the most appropriate initial imaging for this patient? Is it choice A, none, B, mammography, C, ultrasound, or D, MRI? So here the nuance is that this is now a 30-year-old man, whereas before we were talking about men who are going to be under the age of 25. And here now, mammography is the most appropriate initial imaging exam. And going through it, again, we have all the different types of breast imaging tests that can be performed. And you can see for mammography, or if your facility offers 3D or digital breast tomosynthesis, this is going to be the first line of tests we will perform. And then if we see something, ultrasound may then be appropriate. So here is an example. This is a 55-year-old male with a right palpable mass. So you can see we've placed a BB pointing where the palpable finding is, and you can see this looks like it was going to be maybe a nodular gynecomastia. We weren't sure on the ultrasound. You can see this finding hypoechoic mass was a little vague, a little bit some slight vascularity. So when I would describe this finding, I would say corresponding to a palpable lump in the retroareolar region. There is hypoechoic mass, has some microlate margins, it has some little bit of internal vascularity. The differential diagnosis is going to be gynecomastia. That's what it turns out to be most of the time, and we're here really to exclude the chance it's going to be a male breast cancer. So as I mentioned, this is another example of that nodular gynecomastia with usually that fan-shaped density that radiates from the nipple. And this is really thought to be an early phase of gynecomastia. And again, if you see these findings, you're going to give the assessment of BI-RADS to benign finding, and then not to recommend imaging follow-up and reassurance. I'm going to show you another case. This is a 50-year-old male with a right palpable mass. Here you can see this is another pattern of gynecomastia, another example of the variable patterns of gynecomastia in male breast. Is by far the most common diagnosis for palpable lumps in men. So just a few words about benign pathology in the male breast. Luckily, the vast majority, over 99% of all male breast masses are going to be benign. As I've showed you now, gynecomastia is the most common condition. The second most common is lipoma, benign tumor that's entirely fatty. The third one actually is an epidermal inclusion cyst. And less common conditions can include oil cysts, the pseudogynecomastia, that mainly fatty tissue I showed you, hematoma, PASH, and occasionally mastitis or abscess, although the clinical setting here is going to be more when you're suspicious of underlying infection. So I'm just going to show you an example. You can see here this is a male breast. You can see this well-circumscribed mass that has a BB pointing to the palpable abnormality. These two BBs are just placed over the nipple for reference. And under ultrasound, you can see there's a superficial, predominantly anechoic mass. This is what a classic epidermoid inclusion cyst looks like. And just for a companion case to show you another male breast, and what I've tried to outline is this is predominantly lucent fatty mass. You can see there's a capsule around the palpable abnormality Here I'm outlining the MLO view, and this is a large lipoma in a male breast. You can see on sonography, it's going to be this diffuse pattern where it's going to be uniformly hyperechoic, and this is going to show you where the pseudocapsule is, and right beneath here, this is the pectoralis muscle. To summarize these findings, an ultrasound is well-circumscribed homogeneous mass, can be iso, hypo, or hyperechoic, and this is that thin capsule we see on sonography and on mammography. So now let's look at this case. This is a 71-year-old male presenting with a right breast mass. At my institution, we will place a palpable BB marker over the palpable lump. You can see it here. It's much more dense, certainly well seen compared to the other adjacent breast tissue, some lymph nodes. And usually in this case, we'll go ahead and get a spot compression view, which was performed here. You can see it's performed in profiles. You can sort of see the mass and see its margins a little bit more clearly. So this is the next question. In this gentleman, now that we've performed the mammogram, what is the most appropriate next imaging exam for this patient? Is it none? Is it tomosynthesis? Is it ultrasound or MRI? The answer here is choice C, ultrasound. And this is the fourth variant in the ACR appropriateness criteria for the management of symptomatic male breast. The setting of males who are 25 years of age or older, who have an indeterminate palpable mass on clinical breast exam, and then on mammography or clinical breast exam, the imaging finding is indeterminate or suspicious, you'll see that the next best test to do is an ultrasound and not an MRI. So if you go back to this patient, these are the initial mammograms I showed you. And on ultrasound, you can see here there's this round mass, has a little bit of vascularity on the Doppler images, but you can see that it's I would say predominantly hypoechoic, a little bit heterogeneous, and I would describe this as a round high density mass that we see on mammography. And on ultrasound, it's this round heterogeneous mass. This is something that I would want to biopsy. This is not similar to the images of the gynecomastia that I have showed you, and this turned out to be an invasive ductal carcinoma. Just a few facts about male breast cancer presentation. In general, men present a little bit older. The literature shows 67 years, a little bit older than females, about 5 years more. Like breast cancer in females, it usually presents as a painless, palpable lump. Because most of the time, these cancers appear right behind a nipple, men may present with skin or nipple retraction. Paget's disease, which also occurs behind a nipple, is pretty rare in this scenario. And men usually will present at a more advanced stage, so about half of them will have axillary adenopathy at presentation. Occasionally, they may have nipple discharge, and as I alluded to before, we have to be careful about checking for bilateral disease. It's actually about 1 to 2%, and certainly it is higher in men who carry a known diagnosis of Klinefelter's. And of note, on pathology, they do see quite often that there is associated gynecomastia in men who are diagnosed with male breast cancer. So I wanted to talk about the breast cancer subtypes. As I alluded to before, you don't have invasive lobular carcinoma because lobules are pretty rare in men. So by far the most common is going to be invasive ductal carcinoma. We'll see DCIS. And also you can see an infiltrating mammary carcinoma with mixed features and occasionally invasive papillary carcinoma. And I have to say, mets to the breast is extremely rare. So now let's look at this question. This is a 69-year-old with a left palpable abnormality. What is the most appropriate initial imaging for this patient? Is it A, mammography, B, ultrasound, C, MRI, or D, both mammography and ultrasound? So here, we're actually going to recommend both mammogram and ultrasound should be performed. This is the last variant in the appropriateness criteria. And here, we're going to say that a man of any age, and here there's going to be a little bit of there's going to be suspicion for breast cancer based upon the clinical breast exam. And we're talking about initial imaging. Here, you want to do both imaging studies, mammography or the 3D tomosynthesis, along with ultrasound, to really figure out what's going on. And again, for initial imaging, I would not recommend MR. We can consider that after we diagnose a man with invasive breast cancer, but it is not the first-line initial imaging. So let me show you an example. This is a 69-year-old male that has a palpable lump. You can see here is the palpable lump, placed a marker. Something that you'll see right away is actually there's a little bit of some nipple retraction, right? Compared to the opposite side, it's a little bit of pulling in of the breast tissue. Spot compression views, you can see that in fact there's a spiculated mass. And I think you can also appreciate the nipple retraction on this MLO spot compression view. So as we said for this variant, not only do the mammogram, you also do the ultrasound. So compared to other cases of gynecomastia, here you can see the mass here is extending into the skin, and that is what it's accounting for, the nipple retraction. So here, it's the same to the differential. Could it be male breast cancer or gynecomastia? But given these imaging findings, we're going to be much more suspicious for this being a male breast cancer and recommend a biopsy. In this case, it would probably be an ultrasound-guided core biopsy. I'll spend a minute talking about the prognosis for male breast cancer. Overall, the survival rates are lower than in women. It's due to the fact that you're diagnosed at an older age and usually at a more advanced disease of presentation because we're not expecting this diagnosis. Unfortunately, there's a higher prevalence of metastatic disease at the time of diagnosis. However, when studies have adjusted for age at diagnosis and stage of disease, the outcomes are comparable. And the most important prognostic factors are size and nodal status. And overall, the survival rate show that for invasive cancers is a 40% 10-year survival rate. It's higher, close to 80% if it's node negative. So this is one of the summary slides. What I've done here is to review the 5 variants. As I mentioned in the beginning, variant 1 is where we have a very low suspicion. It gets a little bit higher as we go down, with variant 5 being the most suspicious. And along with it, here's a summary of what is the imaging. So if the clinical scenario is really for gynecomastia, pseudogynecomastia, imaging is usually not indicated. Variant 2 for male that are under the age of 25, we usually will start with an ultrasound, and then if we see something suspicious, we'll get mammography. Variant 3, same clinical scenario, but here now, age is greater than 25. Here, we're going to begin with a bilateral mammogram, and that's because mammography is highly sensitive and specific, differentiating benign from malignant disease. And then for variant 4, we're going to present, if it's going to be someone older than 25 presenting again with an indeterminate mass that's already suspicious in mammography, we'll proceed to ultrasound. In the last setting, when we are suspicious, we're going to get mammography and ultrasound. They're complementary. Certainly after this, we'll figure out how to pursue the biopsy. So I'll end with a few take-home points. Imaging starts with mammography for men who are 25 years or older. Ultrasound is quite helpful for the younger patient for problem solving. In general, I've showed you the 3 types of gynecomastia that we'll see. And remember, the vast majority of the palpable abnormalities will be benign. So aside from gynecomastia, it can also include lipoma, oil cyst, abscess, epidermal inclusion cyst. And for breast cancer, when we're looking at imaging studies, we want to see if there's an underlying mass, any calcifications, certainly if there's any skin or nipple symptoms. And on that note, I thank you very much for your attention.